Welcome to Catch the Baby, Keep the Faith, a space where we talk midwifery, motherhood, marriage, and ministry. I'm Kelsey.
And I'm Stacia. We're two midwives, two mamas, and two women trying to follow Jesus through all the beautiful messes of life. We're so glad you're here.
Welcome back to Catch the Baby, Keep the Faith. Today we're doing a little mini episode to respond to a message we got from one of our listeners. First of all, we just want to say how much it means when you share your stories with us. It helps us really know what topics are on your heart and what topics you guys want to hear more of.
Yes, exactly. So this listener, she wrote us to tell us that she had an induction. She labored for several hours and then eventually ended up having a cesarean birth. She did share that she still has some feelings that make her feel a little bit disappointed, and that she's been hearing people say that inductions can often lead to C-sections. She had asked about birth after cesarean and what that looks like. We call that a VBAC. So today we're just going to talk a little bit about inductions, post-date pregnancies, and VBACs, and we're going to try to be pretty objective about the topics and talk about ACOG guidelines and evidence-based resources.
Mm-hmm. So starting off, kind of going into what an induction is. So this is when we stimulate the uterus to start labor. So typically this is used with medication or procedures. We can use like Pitocin, which is a man-made form of the natural hormone oxytocin. We can use prostaglandins like in a medicine called Cytotec or Cervidil. We can use procedures like placing a Foley balloon, breaking water. So there's lots of different ways to stimulate the uterus to start contracting, to dilate the cervix, to kick into labor.
Right. And the way that your provider, whether it's a physician or a midwife, would choose this or recommend it would be highly based on, what your pregnancy has looked like, what your circumstances are. So there's a lot of things that go into that decision. It's not just a one size fits all, like
what your cervix is.
Exactly. So something we wanted to talk about just briefly is when would an induction be recommended? And again, we're just talking to you guys about guidelines, so ACOG guidelines. And so an induction may be recommended by your provider if you are post-date, so meaning greater than 41 weeks, which is probably shocking and surprising to some people. I think some people think, 40 weeks, it's time to have a baby, but realistically, it is super, super normal to go past your due date. But post-dates by definition would be greater than or equal to 41 weeks. Another reason for induction would be a concern for the mom or the baby, like medical conditions affecting the pregnancy. So high blood pressure, diabetes, fluid being too low, sometimes even too high. Maybe the baby's like growth restricted, something like that. If your water breaks, so premature rupture of membranes without labor, and then elective inductions will sometimes be recommended after 39 weeks.
And I think it's like talking about breaking water, when your water breaks, that only happens spontaneously about 10% of the time. Typically, waters don't break on their own. And so if it were to break and you were to not start contracting, there are some things that we can do to kind of help your body along.
Right.
And then, there's risks with anything, and so it is true that inductions used to have a higher rate of C-section, especially if the cervix was not favorable. So like we said earlier, we can choose different induction methods based on what your cervix is. There's a thing called a Bishop score, which is how we actually can kind of rate how favorable your cervix is. And so if your Bishop score was low, your cervix was not favorable. That could, and you choose an induction, or an induction is recommended to you for a medical reason, that could increase your risk of a C-section.
Right.
But more recent data from ACOG, from the ARRIVE trial, shows that elective induction at 39 weeks can actually lower C-section rates compared with waiting.
Just to piggyback off it, but again, that is very dependent, and so we can see it go both ways, right? So yes, an induction may increase your risk of a C-section, or waiting could increase your risk of C-section. So again, there's so much that goes into it. So I think even with all the research that we have and ACOG guidelines, ARRIVE trial, all of those things, like I don't think there's solid it's just not black and white, right? Like you're
Yeah,
going to have increased risk one way or the other, just kind
absolutely.
of dependent on what is going on with
hmm
you.
I do think it's important to know that the Arrive trial was done on first-time moms,
Mhm.
and so this is saying yes, elective inductions at 39 weeks can actually lower C-section rates, but that they only trialed on first-time moms, so
Right.
that doesn't talk to second, third, fourth-time
Mhm.
moms.
Exactly.
And there's so many factors that go into induction, C-section risks. One way or the other, cervical readiness, the reason for the induction, how many weeks you are,
Mhm.
whether it's your first baby, multiple babies, all those
Yeah.
things. So the way the induction is handled,
Mhm.
did we do the right things for your cervix, things like
Right.
that.
And also, things like the Arrive trial and all evidence-based research is it's important for people to understand that it's a small population. When you
Uh
look at
huh.
the whole, like it's still a small population.
Yeah.
So I think we have to be mindful of that too. And
Mhm.
so like your I think it's important from a patient standpoint to trust your providers, right? Like
Mhm. You've
go
chosen
in
that care
yeah, like
team.
you've
Mhm.
chosen them to care for you. You have to go into it with the idea that like we are truly doing what we feel like is best for you and your baby. And
Mhm.
I think if you do that, then the reservation of like am I doing the right thing, it tends to be I guess you tend to feel better about the decision.
Mhm. We did want to give a couple definitions. One of the main reasons why people do choose an induction is because they're technically post dates.
Mhm.
So they're past their due date. The definition of late term pregnancy is 41 weeks to 41 and 6. So really that 41st week of pregnancy.
Mhm.
Um, and then post term is 42 weeks and beyond.
Right.
So you're now 2 weeks past your due date.
And
Um,
so anything less than 42 weeks is by definition still considered elective because 41 and 6, so 41 to 41 and 6 is technically still considered late term, not
mhm.
post dates.
Uh-huh,
So
uh-huh.
while we can say, oh, they're being induced for post dates, by definition, post dates is actually 42 weeks and greater.
Mhm. And typically providers recommend induction late term post
Mhm.
dates,
Mhm.
would be because the risks do gradually increase the longer you go past that
41
41,
weeks, yeah.
42 week mark. The risk for stillbirth does increase a little bit. Meconium state fluid increases. Babies keep growing, and so they get a little bit bigger.
Uh-huh.
Fluid tends to go down a little bit at the end of pregnancy. So because of these risks that do gradually increase, most practices are going to recommend delivery by 42 weeks and typically start discussing induction around 41 weeks.
Right.
And I want to say too, this is all provider dependent. It's all practice
Yes.
dependent.
Yep.
Every practice and provider is going to have different recommendations, different guidelines that they follow,
Right.
different preferences
Yeah.
and comfort levels.
Mhm.
And so always don't go by what we
What we're
say,
saying, yeah.
We're trying
But
to stay objective, like we
yes,
said,
yes.
but
And also, like, I would just encourage you as the patient and your husband and things like I mean, part of it is your responsibility to go into the appointments with questions.
mhm,
And part of it is your responsibility to do a little bit of research
mhm,
and ask these questions because a lot of times from our standpoint, I know like even in what we do is we have a very split I guess idea or concept of what people want, right? We have some moms that are like, I want to be induced at 39 weeks. I don't care about my risk. I don't even want to hear about it, right?
mhm,
And then we have this other group that is like, no, absolutely not. I'm not being induced. I don't. And so we kind of like ride this fine line, right?
mhm,
Because I'm trying to be respectful and supportive of your choices and things that you want, but it has to be a two-way street with a conversation of like,
mhm,
okay, I know you don't want to hear these things. And, we love to use the term like fear mongering and things like that, but I have to tell you these things, right?
mhm,
Like, if we're going to talk about this one, are we talking about a 39-week induction or are we talking about a post dates induction? Like, I have to tell you these things, right?
mhm,
Like, I have to tell you, hey, you could be at an increased risk for this. We could have a failed induction and we end up in a C section,
mhm,
or we could wait and end up in a C section. And so, when we do, and I'm speaking like we, as in Kelsey and I, but as a whole, when we are talking to you about these things and we're telling you these risks, I hope that no one ever feels like we are doing that to force you to make a decision one way or the
Absolutely.
other, or to make you uncomfortable or to scare you, because
Mhm.
some of those things that you listed are very scary,
Yeah.
but they're also very real.
Yep, yep. So a VBAC, a vaginal birth after cesarean.
Mhm.
Because and I if you have a failed induction
Mhm.
or you have a primary C-section for indication by baby, baby's heart rate's dropping in labor, baby's breached the first time,
Mhm.
multiple reasons, that doesn't count you out from ever having a vaginal delivery
Right.
again. So a VBAC is choosing a vaginal birth after a prior cesarean.
And we
We call it TOLAC, a
Right. So I was gonna
try
say we use two terms.
yeah.
Yes. Yeah.
So a trial of labor after cesarean. So
Mhm.
we want to it's a VBAC. You have a VBAC after you've successfully had a vaginal delivery.
Yes.
Prior to that, you are considered TOLAC,
Yeah.
because we're going to trial labor after cesarean, and then once we have a vaginal delivery, then we term it
VBAC.
VBAC.
Yes.
Mhm.
Yes. So the listener that we are talking
Mhm.
about, that she had just mentioned, like, would that be an option, or I'm interested in that, and what does that look like? And I think this is kind of that area where we're like, ooh, do we talk about this, do we not? Because I think it can be very different depending on where you go. There are some facilities and practices that are not comfortable with toe lacking or VBACs, and that's okay. Like, that
Mhm.
is,
Provider
provide,
comfort.
yes,
Mhm.
their
Provider
preference.
skill.
Yeah.
Mhm.
Skill, just preference, things like that. So I think it's important to, one, if that is something that you're interested in, like, well, make sure that the practice that you're going to is comfortable managing it and
Mhm.
can talk to you about what that looks like, what are the risks, things like that. In our practice specifically, we do accept TOLACs. We have plenty of moms that TOLAC and many successful VBACs. Um, the way we handle it is the midwives counsel briefly in the beginning, but then our patients will always meet with one of our physicians
Mhm.
early on in the pregnancy, midway through the pregnancy, and then we try again towards the end, just to do like 3 different sets of counseling.
Mhm.
And at that visit, the physician will kind of, talk to the patient and go over, what was your first C-section for? What is your plans for future children? And ask all these questions. And then they are really the ones that kind of give the percentage of what is your success rate of having a successful
Mhm.
VBAC.
And I think with all of these meetings that we try to set our patients up for, it's not to, scare them, and it's not to
No,
push
yeah,
them one way or the other, but it's to provide information so that you as the patient can make an informed decision for yourself and for your baby, for your birth that you
sure.
desire.
And so just part of the counseling would just, understanding that decision is very individualized, right?
Mhm.
Like, it is not, again, I think I said this earlier, it's not a one size fits all when it comes to that, depending on, I think I said this, what your C-section was for, what type of scar, which way the scar was made, any other comorbidities, things like that. And then who would be a good candidate. So that kind of is up in the air too, but most practices look at it as, if you've had one prior C-section,
Mhm.
then you could potentially be a good candidate depending on what that C-section was for. No history of a uterine rupture, no extensive uterine surgery. So, something that sometimes people will have will be a myomectomy or something like
Mhm.
that, and again, these are definitions and things that we might talk about later on. And then,
We're gonna give y'all homework to go and
yeah, go
look up
research this
some.
a little bit. Clinically appropriate pregnancy. So typically people will say, you know, not a twin gestation, right?
Mhm.
Like, they wouldn't want you to toe lack on that. No placenta previa. So just
Baby's head
overall,
down.
yes,
Uh-huh.
a low risk,
Mhm.
uncomplicated pregnancy would be ideal.
And then, there's benefits and risks to anything,
Sure.
like we said
Hmm.
earlier. So, a benefit of a VBAC would be that shorter recovery, a less risk of infection because you
Hmm.
have not had abdominal surgery. Um, and then typically the success rate of a VBAC is about 60 to 80%,
Hmm.
depending on the circumstances. And so that's a huge part of this whole thing being individualized, that it's going to depend on the circumstances of your pregnancy, your
Right.
uterus, your baby, your cervix, all those things.
Hmm. Hmm. And, just to piggyback off of what Kelsey said, so, yes, there's benefits, there's also risks. You're going to be at an increased risk for a uterine rupture because of the history of that incision on your uterus. And then
And that risk is about
it's
0.5 to
low. Yeah.
1%. It's
Yeah.
low,
Hmm.
but again, that's one of the things that we're going to counsel you on, is that you are at an increased risk of this because of
Right.
your
And
history
it
of a
sounds like a
C-section.
low percent, but we see it more often than you think, which is a hard
Uh-huh.
concept to understand, right? It's like overall evidence kind of
Mhm.
shows the a low percentage, but I think the other part, and the part of the counseling, is that when it does happen, it becomes an emergency,
Yes.
right?
Mhm.
Like it's not that happens and we're like, okay, now we have to
Mhm.
go. No, then things become emergent. And so I do think that is something that people need to understand as
Mhm.
well.
Mhm. And all of this, no matter where your practice is, who your provider is, it's having that shared decision making,
Hmm.
having those personalized
Yeah.
conversations, building that trust, that rapport, asking the hard questions to your provider,
Hmm.
and but expecting them to give you hard answers back,
Yeah.
and honest answers, so that you can really make that an informed decision for
Yeah.
what you feel like is best for you.
Yeah, and understanding again, like you have to come with questions. Like you
Yeah.
have to do some of the leg work on your own and not expecting us to make the decision for you.
And I think that goes with a lot of things in pregnancy, decisions in
Mhm.
pregnancy,
Mhm.
whether you decide as a first time mom, or as, deciding again, like for an induction the first time ever,
Right.
coming with the questions about what an induction might look like
Mhm.
prior, like regardless of prior history, um, all the things in
Yeah.
pregnancy.
And then not specifically just talking about toe lacking, but I am talking about that right now, but in general, I think it's super important to go into these meetings and counselings and things with an open mind,
Hmm.
and not coming in with a like, this is the plan, this is what it's going to be, and I'm not wavering from this,
Hmm.
right? Because again, we don't tell you these things to scare you, we don't tell you these things, to make you do one thing or the other, but I just encourage people to really go in with an open mind and hear what your provider is saying,
Hmm.
and then
Benefits and risks, like, and
yeah.
I think we're maybe harping on risks more right now, but like benefits as
But
well.
benefits too,
Yeah.
yeah, and just understanding like you also have the ability to change your mind at any point in time. And
Absolutely.
that's something I always tell those moms is like, I don't ever want you to feel pressured one way or the other. But say you decide, okay, I'm going to do this. This is what I want. And then at the end of the pregnancy, you change your mind. Like, that's okay too. You just
Mhm.
have to keep your providers informed and make sure everyone's on the same page. And then just fully being transparent of what that's going to look like. There are some providers that will say, yes, we do TOLACs, but you have to labor on your own,
Mhm.
right? Like we're not going to induce you. And then there's some providers that are comfortable with
Mhm.
induction. So it's just really understanding and being comfortable with your provider, but going in with the idea of like, okay, I need to also ask the questions so that I don't leave here feeling like, well, I didn't understand anything. Like you
Mhm.
have to be prepared for it too.
Yeah, absolutely. And I think as midwives,
Hmm.
as believers, we can see how birth can bring joy and disappointment.
Absolutely.
So I think it's okay to grieve when things don't go the way you hoped.
Hmm.
And that was what this listener had said, that she
Yeah.
was disappointed, and that's a valid feeling, absolutely.
Hmm.
But it's also okay to celebrate the beauty of your story in
Yeah.
whatever capacity that looks like,
Right.
whatever form your birth took shape,
Hmm.
whatever, however your pregnancy turned out. Like, there is grief and beauty
Hmm.
in all of those aspects.
And learning to find that, right? and
Uh-huh.
and maybe it's conversations like this, understanding like, hey, we did choose to do this and it was with your best interest and the baby's best interest, and it didn't end the way that we wanted, but like sometimes just truly fully understanding why kind of helps you feel that way. And then just remembering that God redeems every story, whether it's an induction, a C-section, a
Mhm.
VBAC.
Mhm.
Your experience matters, and we believe that as believers, we believe that as midwives.
Mhm.
And you're not alone in it. There is someone out there that has a similar story, and I just encourage you to kind of dig deep in that, and
Mhm.
and ask those hard questions,
Mhm.
and don't be embarrassed when you are feeling sad or
Mhm.
guilty, or
Mhm.
whatever those feelings are. I think talking to your friends and your
Mhm.
spouse and even your
Your providers,
provider,
yes.
yeah, and
Mhm.
and asking those questions, and sometimes doing that, you will come out of it with a much clearer understanding, and
Mhm.
you can maybe finally get the healing and the peace and the understanding that you've been looking for.
Yep, absolutely. Well, this was a really fun little mini
Yeah.
episode. We just wanted to touch on that topic because this listener had listened to our last episode
Mhm.
um, about faith in the birth room, and so we thank you for
Mhm.
your
Yes,
message.
thank you
Thank you
so
for bringing
much.
up this good topic. If you have topics like this, short little questions that we can just do a quick little mini episode on, kind of cover, give you objective information,
Mhm.
but also hopefully give you like a faith perspective from it.
Yeah.
We'd love for you to message us, email us, and so that we can just kind of dive in.
Yes.
I've just put up a Q&A on our Instagram story, so go and answer the Q&A.
Mhm.
I think our next episode will just be a fun Q&A
Yes, we'll
episode.
try to do that, and some of them might just be quick answers that we
Yeah.
put on our stories and things like that, but we definitely want you guys to be engaged and
Mhm.
giving us your ideas so we can truly understand, what it is you guys like to hear and
Yep.
don't like to hear.
Yep. Well, thank you so much.
And then
Follow along, share
yes,
this.
and until next time, remember to catch the baby and keep the faith.